Hello and welcome to a special interview for The Wire. With India's COVID-19 cases increasing by almost 100,000 a day, the only comfort comes from India's low mortality rate. But that raises a key question. How accurately is the death count actually assessed? Is it an underestimation or is it genuine? Those are two key issues I shall raise today with Professor of Community Medicine at the All India Institute of Medical Sciences, Anand Krishnan. Professor Krishnan, in a recent article you wrote for The Hindu, you say of the official death count, and I'm quoting, "Nobody believes this number to be true, yet nobody has an alternative number." Let's first talk about why you think nobody believes the number is true. One of your reasons is to do with the country's mortality surveillance system. What's the problem here?
Okay, first of all, let me thank you for inviting me to this show, and also more importantly focusing on a very critical aspect of public health, which is related to mortality surveillance. The reason why I say that we don't believe that number, there are two big reasons. Number one is that almost all countries in the world, including developed countries like US, UK, believe their reported count is less than what is the real. And I see that no reason for India to be different from that. The second reason is that in India, there is no disease for which we don't, our reported number is not the correct one. And again, therefore, I don't see COVID to be different from other diseases. Therefore, I don't expect the reported number to be the true estimate of number of deaths in the country.
But what is the specific problem with the mortality surveillance system?
Okay, to really believe a reported number, we need to do two things correctly. Number, all deaths should get reported to a system, and for all of them, we should have a cause of death. If both these conditions are fulfilled, we could say that the reported deaths should be equal to the actual deaths.
And that's not the case in India.
Both are not true in case of India. Neither do we report all deaths get reported, nor do all deaths get a cause of death assigned to them.
In fact, the figures are shockingly low. Just for the sake of the audience, I'll quote them. Only 86% of deaths are registered, but in some states, it's as low as 61 in UP, 55 in Jharkhand, 35 in Bihar. And secondly, only 22% of deaths are certified by a doctor. But again, there are many states where it's a lot lower. It's 7.4% in Madhya Pradesh, 5% in Jharkhand, 2.6% in Bihar, and 2.5% in Jharkhand. This means that actually in these states, Madhya Pradesh, UP, Jharkhand, Bihar, over 90% of deaths happen without a doctor certifying and without anyone really knowing what is the cause of death.
Perfectly true. So there are some states like Kerala and Goa which do pretty well. They do almost 100% registration.
But in terms of population, they're very small.
Yeah, exactly. So, and UP, Bihar, which are in terms of population very large, are doing very badly, and therefore the national averages come down. See, for example, for a doctor to assign a cause of death, the doctor has to see the patient before the patient dies, right? So that he can make a judgment. And for that, the patient has to reach a hospital. Unfortunately, only about 30% of deaths in India occur in a hospital. Almost 70% or 65 to 70% of deaths don't occur in a hospital. They occur at home largely. And therefore, doctors do not see them and therefore do not assign a cause of death.
Now, as you point out in your Hindu article, the inherent weaknesses in our mortality surveillance system are exacerbated by COVID. Can you explain how COVID exacerbates these weaknesses?
So see, there are three basic causes, basic sources of data on deaths in India. One is the vital registration, when all of us register our births and deaths. That does not give us any cause, it just tells us the number. The second is the medical certification, and we talked about that.
That's very low, 22%.
Yeah. And third, and I will come to that later, is what is called as a sample registration system. India admitted that India cannot have a good mortality surveillance system, which will be national in this thing. So we selected small parts of countries as a sample and do a good job of counting all deaths and assigning causes of death of them. That's what is called as a sample registration system. That is what gives us the data for most of the causes in India.
COVID, as you point out in your Hindu article, has made this whole process of registration and medical certification even weaker still. You say COVID has adversely impacted death registrations due to lockdowns, travel restrictions, as well as the social stigma resulting in people hiding these deaths. So whatever is anyway weak for other deaths becomes even weaker still for COVID.
Yeah, so let's take at birth and death registration. Out of the three sources, let us take the first one. Obviously, during the time of this time, many people, because of the lockdowns and the restrictions, people, even if they wanted to report, they would face restrictions in reporting. And definitely most people, this is not a priority work that they want to do. So given a sort of barriers, they would just not report.
So a lot of COVID deaths are simply not getting reported because of the stigma, because of lockdowns, and because of other barriers that you're talking about.
Yeah, and as we saw, at least the anecdotal reports from the newspapers, that many people who need to be hospitalized are not getting into hospital because of access issues. Therefore,
so they're dying at home.
They're probably dying at home, and we don't know how they get reported in our official systems. So again, we are missing them as well.
So now in your Hindu article, in addition to the weakness of the mortality surveillance system, which we've discussed, and how this is exacerbated in particular by COVID, you also have two other reasons for believing that India's official death count of COVID is unbelievable. The first is the fact that you have something called suspected COVID deaths, but these are not attributed to COVID because the death has happened without a test. Can you explain this to the audience?
Okay, I would not use the term believable in what you said. See, we have to understand we work with limitations in the Indian system, and we have to accept those systems. Definitely, when it is an underestimation, belief is a subjective this thing. I'm a scientist. I go by objective measures.
Professor Krishnan, believe is the word you used. Your Hindu article says nobody believes this number to be true.
Yeah,
I'm using your word.
I agree. So that's the first point. Second, let's look at the COVID specific issues. See, for a death to be 100% sure that this is to COVID, two things have to happen. First, person has to present with a clinical picture which is consistent with COVID, like fever, breathlessness. And then we do a test, and that test comes positive. So if both are true, then one can be certain that the cause of death is due to COVID.
Now you talk of a category of people who have suspected COVID and have died. They have the symptoms of COVID, but they haven't been tested before death. As a result, there is good reason to believe this is a COVID death, but it's not counted and categorized as a COVID death because the test wasn't done.
Yeah. So now, if these are the two conditions, you can have two sides of situation. They are clinically consistent but don't have a test, or they have a positive test but they are not clinically consistent with the COVID. So let us take each one of them one by one. The first one, in the example that you give, ultimately COVID is sort of like a pneumonia. Most of the respiratory symptoms are so. Do you believe that anybody who dies of pneumonia during this period has died of COVID? The answer would be no. Pneumonia is caused by a lot of other organisms, bacterial as well as viral, let's say for example influenza. So not all people who have a clinical picture which is consistent with COVID are going to have COVID.
But some will.
Some of them will have. The number will depend upon the season. For example, influenza is higher during August and September.
And the point you're making is that figure who have the symptoms of COVID and die, and who actually are dying of COVID, we never really find out about and count because they're not tested.
Exactly. So that's true.
And because they're not tested, they don't feature in the tally of COVID deaths.
Yeah.
So this is another sense in which the tally of COVID deaths is not accurate.
I agree. Definitely, that's true.
And I believe this has been made worse by the fact that in June, the Indian Council of Medical Research issued a guideline which says that after June, a dead body must not be tested for COVID, which means that if a doctor believes you have all the symptoms and you've died of what he thinks is COVID, he can't prove it by testing because the ICMR has said you can't test a dead body.
See, I don't think the issue of guidelines on testing dead body has anything to do with cause of death. To me,
not cause of death. Finding out after death what was the cause.
Yeah, so again, let's say that in the example that I gave, there could be people who are not consistent with their clinical picture. They have died, let's say, for heart attack, but you test them for COVID and they are positive. It could be an incidental finding that.
But we are coming to another category. Let's take these categories one by one. Let's stick first to suspected COVID deaths. These are people who've died, who have the symptoms of COVID. You have reason to believe this is a COVID death, but the ICMR after June has said you can't test a dead body. So since you can't test a dead body, you can never confirm whether your suspicions are correct or wrong.
Yeah, so see, again, ICMR guidelines were not to do with diagnosing COVID. It is to do with, because at that point of time, there were people, if they were taking a body to a crematorium, the people were asking, tell us whether they are COVID positive or negative. So this was more to deal with disposal of the body and preventing infection rather than arriving at cause of death.
I understand.
So those guidelines are nothing to do with arriving at cause of death.
I understand that the guidelines were intended to actually allay concerns at crematoriums and burial grounds.
Yeah.
But the guidelines also had an impact on the fact that you couldn't hereafter test a body to see whether the person had died of COVID.
So here you are assuming that if it is quite possible, then it depends entirely on the certifying doctor. If he feels that the clinical picture was consistent and with history, that he has a history of contact with COVID, he could still have certified that death as a COVID death.
Except
so
that
we don't know what the
except
certifying
that he
doctor
would
did.
be certifying on the basis of his
clinical.
analysis,
Yeah.
not on the basis of a test.
Yeah,
That
he will be
test will
certifying
not
on the
be-
basis of judgment.
So what I'm saying is, the problem that you talked about, suspected COVID deaths never being counted as COVID deaths because there was no testing done, is exacerbated by the fact that after June, you can't test a dead body.
My guess would be that I don't think that would be an important contributor to underestimation of.
Let's come then to another category, which you write about in your Hindu article, where you believe people who have died of COVID are not being counted as COVID deaths. You point out that COVID exacerbates comorbidities such as TB, diabetes, heart trouble, high blood pressure, and quite often people die as a result. You say that these deaths are attributed to the comorbidity, not to COVID. Here I want to ask you, are you absolutely sure that they are attributed to the comorbidity and not to COVID as well?
Okay, so as I said, so when we are looking at COVID-related deaths, there are two kinds of categories. One is the direct, where the COVID has directly resulted in a death. And the second group of categories is the indirectly caused deaths, which COVID is not directly responsible. Therefore, for example, as I said, it is quite possible that COVID has exacerbated a chronic heart condition and precipitated an heart attack.
Are such deaths counted as COVID deaths or not?
Again, this is a judgment of the person who is certifying the case, medical certification. They may quite possibly not certify them as a COVID death.
So there are again some deaths that you believe COVID is the cause of, but are not certified as COVID deaths.
Yeah, they are indirectly caused by COVID. So one has to be careful when we say COVID-related death. Are we talking of direct COVID-related deaths or indirectly
This
related
term
deaths?
indirectly caused by COVID is actually, forgive me, a little spurious, because if COVID hadn't happened, the heart condition or the diabetes wouldn't have exacerbated.
I fully agree
so
with you.
clearly, the exacerbation of the comorbidity is due to COVID, and therefore, to distinguish between a direct and an indirect death is meaningless. COVID caused the death, because if COVID hadn't happened, the heart problem wouldn't have happened.
So in a way, I agree with you. It's not that I'm not agreeing with you. The only thing that probably that person would have had an MI maybe 1 year, 2 years down the line. COVID precipitated it to occur much earlier, and therefore, in a way, this death at this point of time was due to COVID.
But it's not always counted as a COVID death, you're saying.
It may not be counted.
Are there not ICMR guidelines that say that if you die of a comorbidity but you also have COVID, COVID must at least be mentioned on the registration or the certification? Are there not such guidelines?
See, when we the cause of death which is usually used is what is called as an underlying cause of death, right? And contributory cause of death. So somebody, let's say, has an MI and he is COVID positive. It's entirely a judgment by the clinician whether that COVID contributed or just was associated, or it was an associated condition. Therefore, then we will put it as an associated feature rather than as an underlying cause of death.
So you're saying
it's a clinical judgment.
So you're saying many clinicians in their judgment either may mention COVID or may not.
Yeah, exactly.
And to the extent they don't mention COVID, once again, the tally of COVID deaths is an underestimation.
Yeah, I agree.
Now, I take it there must be at least one other reason why the tally of COVID deaths is an underestimation, and that's because as the disease and its incidence moves from metropolitan cities like Delhi, Bombay, Calcutta, Chennai, into small towns, and then further into rural India, which is what is increasingly happening, there you have lack of hospitals, often you have an absence of doctors, people will die, and people won't know whether they died of COVID or not. In rural India and small towns, this problem of underestimating COVID deaths, because you simply can't identify them, will probably be greater.
I fully agree. See, if you look at medical certification, which is our main source of cause of death, is highly urban bias. It's almost, and there is a serious If you compare between urban and rural, the difference is huge. So yes, as the epidemic moves more towards rural areas, we expect underestimations to worsen.
So with every passing day, as the incidence of the disease moves into rural India, the degree to which we underestimate COVID deaths will grow worse.
Probably yes.
So just to sum up this part of the interview, there are many reasons that we've discussed. Reasons to do with the mortality surveillance system, reasons to do with suspected COVID deaths or COVID-related deaths not being counted as COVID deaths, and finally reasons to do with the fact that in rural India you simply don't have the certification procedure. For many of these reasons, there is actually a huge underestimation. Do you have any sense of how large this underestimation of COVID deaths is?
I would be hesitant to, because there are too many factors being played out and it will be very difficult to say which plays how much. So I would be very hesitant to put a number to this.
Don't put a number. Give me some order of magnitude. Don't put a number.
But order of magnitude means a number.
But are we underestimating by 25%?
No, single number is out of question. Anybody who gives single number simply doesn't know, understand the complexity
what's
of
your hunch? Are we underestimating by 20%, 25, 30, 40, 50? Give me your hunch.
I'm not going to fall into that trap of giving variant. I can tell you for many diseases.
Let me reverse the question. Is it a small and therefore negligible underestimation, or is it a worryingly large one?
Again, as I said, it's a moving, and you yourself agreed to it, that its underestimation is likely to be lesser in the urban, which is what till now it has been.
And greater in rural.
And greater in the rural. So whatever I say is actually going to be useless after some time, because our current underestimation will be based more on our estimate of urban areas where I don't expect it to be a very big number.
But as it goes to rural, the number will grow.
Yes, I expect it to worsen.
So as we agreed, the underestimation will progressively get worse.
Yes, there's no doubt about that.
Now, in your Hindu article, you suggest that there is a better way of assessing COVID deaths, and you say that is by calculating what you call excess death, comparing the last 6 months or the last year with the year before. Very briefly, can you explain to the audience how do you calculate an excess death?
Yeah. See, if you cannot, you don't have enough systems that you can directly count the number of cases, we'll have to go for an estimation procedures. And one has to understand that all estimation procedures have their own inherent problems and errors, both because of the data constraints as well as because of the model that we use. So one model that is used is an excess death, which it simply says if COVID had not occurred, how many deaths we would expect in this period of time. And given what we have what is the excess death, and all excess deaths are in a way attributed to the COVID. That's the basic logic.
So in a very simple sense, you could do what Mumbai Municipal Corporation has done, because they've recently released what they believe are excess deaths between the 1st of March and the 31st of July. They say the deaths that took place in this 5-month period this year were 13,058 more than the same 5-month period last year. So they say excess deaths, and this is BMC officially certifying it, excess deaths is 13,058. At the same time, during the same 5-month period, COVID deaths were officially said to be 6,395. That means the excess deaths were 100% more and a little bit more than the COVID deaths. That's the order of difference in Mumbai.
Okay, I don't agree with what.
But this is their official figures.
Let me tell you why. Give me a chance to explain. First is the concept of excess is based on a baseline, right? Without a good baseline, excess will not hold true. So the question is, how do we establish a baseline for a cause of death?
Well, you take, I presume, the average of the preceding 3-4 years.
Exactly. So
what makes you think Mumbai hasn't done that?
I don't know.
So
if they have compared this year with last year's, then that is single year, right?
No. I'm saying that Mumbai has officially released their excess deaths. They would have obviously done it in a sensible, scientific way.
I don't know. I don't assume those things.
Well, let's for conversation's sake not assume that Mumbai is an idiotic organization. Let's give them the respect of intelligence. They have officially announced that the excess deaths are 13,058. COVID deaths was 6,300. All I'm pointing out is this, that the excess deaths are more than 100% the COVID deaths, which means there's a huge margin of excess deaths that are not counted.
Yeah, so again, I'm not going to comment on that estimate.
I'm not asking you to.
No, just hold on. Because, as I said, I'm not sure how they have defined baseline. Second, there is always an inherent variation. Every year it does not appear the same, and therefore, just hold on. Statistically, when we define a baseline, we give with a what we call as a standard deviation or a range.
I understand.
So anybody who gives a single point estimate does not know his statistics, and I would never believe an estimate which is 1 point.
Let's, for argument's sake, accept that a figure released by the government is correct. Mumbai Municipal Corporation is part of the government structure of India's second city. Let's accept their figures are correct. Let's not quarrel about their figures. Let me instead put a more important point to you. I'm asking you to think ahead. If the excess deaths are 100% more than the COVID deaths, that means arguably there are a lot of COVID deaths you're missing. That's the point I'm making.
Yeah, so first point, I think if we are not even, if we are agreeing that government is putting out the correct amount of deaths, I don't think we should be having this conversation. I think the whole starting point of this conversation is that the government's numbers are not necessarily true.
Except, sir, you were talking about COVID deaths, I'm not talking about excess deaths.
No, ultimately it's a whole issue of death reporting.
But hang on, the point is this, don't you accept that if excess...
No, it's a whole issue about accepting government's data. Okay. So if you accept one data and you don't accept one data, I have problems with that. I have suspicion with all data sets, with all governments. It's nothing to do with any
let me put
specific
the question
government.
differently. Yeah. You're quarreling as an academic, as you have every right to do, with the way you believe these figures have been announced, and you think that perhaps Mumbai should have announced them with a spread rather than a single figure. You may be right. Let me point something else to you. If there's a huge if there, if the excess deaths are 100% more than just the COVID deaths, what percentage of these excess deaths do you think are likely to be COVID but not acknowledged as COVID? Do you have any sense of that?
Again, see, the two things. First is that we have to be clear that these COVID deaths, excess deaths include both direct and indirect COVID related. That's number one. Number two, remember that we could have a worse, all excess deaths may or may not be attributable to COVID. If I am in
what percentage are?
Just hold it. If I am in Mumbai, I would look at it age specific. I would look at it with cost specific, and from a judgment that would give me a better hang. Because, for example, if I find that the excess death is in under 5 age groups, then I would be very suspicious whether this excess is due to COVID. So one has to be clear.
But the problem is this, so you're the one who suggested in your Hindu article that a better way of calculating COVID deaths is through the excess route.
I still agree to that.
Now you're finding faults with the excess route. So you're arguing against your own proposal.
No, I am saying when we use the approach of excess death, we have to look at it by age, by cause of death, to understand it better rather than just, so I still propose excess death as an approach, but it needs much more careful way to do things like that.
Let me point out a problem with the excess death approach to calculate the number of COVID deaths. When you are calculating excess deaths at a time when there's a lockdown, there's also a reduction in deaths through road accidents, through pollution. How do you calculate that reduction?
Exactly, that's why I'm saying we need to look at with the cause of death. So I would also analyze the same set of data to see what happened to accidents during that period, what happened to different conditions. So a final judgment on excess death has to be a more guarded one, looking at the age distribution of excess death, cost distribution of excess death, and then arrive at a probable estimate.
So we are reaching a situation where we've established two things. You don't believe that the government's official count of COVID deaths is believable. That's your word. You used it in your article, right? And there are many reasons why you have fault with it. You also believe that as the incidence of the disease moves from urban into rural India, the undercounting, the underestimating will get bigger and bigger and bigger. However, using the excess death method is neither simple nor easy. A, because you have to account for the fact that deaths because of road accidents, deaths because of pollution will have come down. Secondly, all the excess deaths may not necessarily be COVID deaths. Some people will die not because of COVID, but because they can't get to a hospital, because hospitals are packed up with COVID patients. So even the excess death route, you think may be a preferable way, but it's not an easy way. and it still doesn't give you a clear idea of how many deaths you're missing. Have I summed that up correctly?
Yeah, I think reasonably less, I would agree to that. It's a complex process. Anybody who tries to simplify it is going to land up into
So
a
this
soup.
is a very complicated issue.
Yeah.
All you're saying is two things. One, the deaths officially announced are an underestimation, but working out the actual number of deaths is very difficult, and we can't guess how large the underestimation is. You will not put a figure on it.
Agreed.
However, just before the Hindu published your article, on the 10th of August, they published an article by Hemant Shivade and Giridhar Gopal. I believe Giridhar Gopal is actually one of your students.
Yeah.
You are the mentor for his PhD,
Yeah.
so you know his work extremely well.
Yeah.
They estimated that the extent to which India is underestimating COVID deaths is by a factor of 5.29. As Giridhar Gopal's teacher, how do you respond to that result?
I think again it's a matter of oversimplification. I do not agree to that number of 5.29. They just multiplied by the under certification, the medical certification of cause of death. It's about 21% of the deaths are certified, so just simply multiplied by 5.29. Again, a case of an extremely simplistic approach to this problem, which needs a much more complex and careful approach. So I don't agree to that estimate.
You're actually passing a very, forgive my language, damning judgment on that article. It's oversimplistic.
In fact, I told him personally that what they have done is not right. So I have said it to him openly. So
That this is not right.
no, I agree.
Because the extrapolation from their work, and I'm simply pointing it out because that's an extent to which you can ask yourself the question, are they right or wrong? The extrapolation is that as of today, the official death count is 77,500. If it's underestimated by 5.29, that means the actual truthful death count would be just over 410,000. That would be double America today. That's one reason for saying this simply doesn't feel right.
I don't think we should play with numbers so easily and get some estimates out for India in such a cavalier fashion, if I may put it so.
So we end then with the following conclusion. I'll put it to you and you tell me whether it's right or wrong. The official figure is hard to believe being your word. It's an underestimation. There are several reasons why that underestimation has happened. That underestimation will get worse as the disease moves from urban to rural India. But it is almost impossible to say by how much we are underestimating. It's impossible to put a figure on the underestimation. The alternative way of counting is what you call the excess death method, but that's not simple and easy, and it has to be done very carefully. And again, you have great problems with the figures tossed out by Mumbai Municipal Corporation because they haven't given all the supporting details. So this is a complicated, difficult issue, and all we can really say is that the official death figure is an underestimation. That's about all we can say.
Yeah, I agree to that.
How much comfort then can the Indian government get by constantly pointing out that our mortality rate is very low?
See, low, it's a relative term. Definitely, India seems to have much lower mortality than many other countries. So, to some extent, one can claim credit for it.
Our death rate is higher than Pakistan, Sri Lanka, Bangladesh.
Yeah.
It's higher than the whole of sub-Saharan Africa. It's higher than the Philippines, Malaysia, Thailand.
Yeah,
So,
I agree.
it may be low, but there are many countries just around us lower than us.
Yes.
So, my question comes back. How much comfort can the government of India get from this low mortality rate, particularly if the low mortality rate itself is an underestimation?
I would be cautious in getting comfort out of that. I would not, I don't think that's a point that we should be stressing too much, that our low mortality rate.
Professor Krishnan, for that clear answer, thank you very much indeed. Take care, stay safe.
Thank you. Thank you very much.
द वायर के और वीडियोस देखने के लिए सब्सक्राइब करें और बेल आइकन पर क्लिक करें। स्वतंत्र पत्रकारिता की आर्थिक मदद करने के लिए डिस्क्रिप्शन में दिए गए लिंक पर जाएं और अपनी राशि चुनें।